Hey there, Lee Kinnear here. We had set up a procedural workshop, but unfortunately, due to some distancing concerns, we're going to have to do it virtually. We do a lot of injections in our clinic over here. I prefer to do nearly every injection that I perform under ultrasound. I understand that not everybody has that luxury, so we'll talk today about the ones that I think would be safe to consider under palpation guidance or landmark guidance, and ones that I think definitely need a referral to someone who can do it under ultrasound. And certainly understanding that these injections, every one of them has been done before the advent of ultrasound, but the more deep injections, even then, were done under fluoro. So we'll talk more about some superficial structures. But I think the first thing to really appreciate is why we do injections to begin with. We do injections of anti-inflammatories like a corticosteroid as a fire extinguisher. I tell my patients it puts out a small fire, and so it in and of itself, when I'm approaching a patient to consider an injection, it's really the process I'm going through is, do I think this patient can get in and do the things that they need to do in physical therapy without an injection, or is this someone who's going to likely run into a barrier pain-wise that we can remove temporarily with an injection, so that whenever they get into physical therapy, they do the right things to treat the true issue. When the steroid wears off, which is going to be in no more than a few weeks, that they're in a better position anyway because they've had some time to make some mechanical changes. So also things to consider obviously would be blood sugar issues, right? I do not do corticosteroid injections on patients with uncontrolled diabetes. I don't typically do 2 steroid injections. Let's say somebody comes in and they've got a rotator cuff issue and a swollen knee. If you have diabetes, even well-controlled diabetes, I've just had too many issues with patients calling back saying that their blood sugars were in the 300s or so a couple of days later, the next day. And, obviously first, do no harm, and I don't want to expose patients to excessive risk for something that really is going to give them some temporary benefit anyway. So patients with diabetes, I will give them an injection and tell them a week later if this other issue, the secondary issue, is still a problem, then come back and we can do a second injection. And I know that's a bit of an imposition for the patient, an inconvenience for sure, but I think that's a better outcome than trying to give them 2 corticosteroid injections and have them manage the consequences just from home. I also want them to reach out to their primary care physician after they get a steroid injection, and I also give them some guidelines saying, expect that tomorrow even well-controlled blood sugars are going to be elevated. That doesn't mean you necessarily need to go to the hospital, and also not to change. I mean, you guys are better at this than I am, but I tell them not typically to change any of their longer-acting medications if they're on a long-acting insulin, because that bump in their blood sugar is going to go down just as fast as it came up, and you don't want them to be too low. So